So as Sarah mentioned, I am the past chair of our certification board in Hamilton, or in Canada. I was the lead for the core competencies I'm going to discuss, and I'm currently a representative for internal medicine on our specialty committee for the Royal College. What I want to do in the next few minutes is discuss some of the variations in critical care education around the world, learn what is meant by competency in health education and how it may address some of the issues of going through the continuum of training. We all should still be learning as we're sitting here today. Learn about competency by design evolution in Canada and what we're doing. And understand the vision for what critical care training might look like in terms of the Entrustable Professional Acts. And I'm very curious to have some discussion, particularly from our Australian, New Zealand colleagues, because they've been doing some version of the same for a number of years. So here's the problem. While medical education systems in general produce good healthcare professionals out the other end, there are gaps and challenges. And this article particularly just talks about the fact that, as Francesca mentioned, with all of the technology and else going on, have we really prepared our trainees to be there in the real world? I see it in the interprofessional setting that we've got increasingly concerned about our nursing colleagues when they've been trained in an environment, and can they actually hit the ground running once they finish that training as well. So we need to improve the system. First of all, we need to address the changes in our patient population, particularly what was critical care 10 years ago when I started is not the same critical care anymore. Those of you who are younger may not remember the ARDS with 10 chest tubes, right? And we need to be accountable for what society's expecting of us. We need to assess competence, but teach for excellence, right? We're not going to achieve it necessarily at the end of training. And we need to ensure that all competencies evolve as we move forward to a continuum through to retirement, and I'll leave that for Dominic to discuss a bit. And finally, we have to be flexible. We have to be flexible because we now take trainees, at least in Canada, and we have to accommodate their learning styles, their learning ability over time. They may have the capacity to learn, but how they learn may be different from one individual to another. And there's increasing public concern about some of our colleagues out there and their capacity to perform. These are just 3 editorial evidences of different physicians who've been in the media in Canada in the last little while, and failure to maintain a practice to the standards for which they are expected in their profession. The pathologist one was particularly horrid. So let's take back and define competency. And this isn't a new concept. Our teachers who teach our children have been doing this for years. And other health professions have been doing this for years. So why has it taken the physician group so long to get to it? And, you know, the work that Francesca did with Cobatrice started some of that idea with competencies. It's challenging in the European Union because every country had a little different program, but it was out there. So let's talk about the knowledge, the skills, the behaviors, which we don't always address in learning, and how did you behave in this, the values, and having an ability to provide a specific role. So I showed this yesterday. Let's come back to what competency is. Many healthcare organizations that train health professionals are using the CanMeds or some form of it now around the world. But what the object on the other side, I didn't bring the pointer, talks about what we're doing now in terms of competency by design within the Canadian context. So if you take the newly graduated physician or the newly trained specialist, there's going to be a transition to learning about that particular role. And in Canada, we don't have an internship for those. We start right into a residency program. Then you have a period where there's a bit of foundation. Then you're going to learn the core of whatever that specialty training is. You'll see an examination in there. It may move a little, wander from place, but that's ultimately where we hope to get, is at the end of that core. And then there's a period of time in which we hope to be able to observe that trainee who's passed a knowledge exam, but needs to be able to demonstrate their capacity to be independent in practice and have some additional acts that we expect of them. And then following from that, their continuing practice. And I don't know about your part of the world, but we have a number of physicians who haven't got a retirement plan, haven't got the capacity to recognize when they're not able to maintain that competence and their skills may not be up, capacity to keep up with new knowledge. So how do you transition out of practice? So there are so many versions of critical care around the world. Francesca published a paper over a decade ago of just the variation in critical care training around the world. And some of you now have programs in the world where you start straight out of medical school. But in Canada, critical care training is a subspecialty. And it's probably one of the broadest in the world as to how you can get to be an intensivist in Canada. We have multiple entry routes. Either you start internal medicine or pediatrics or emergency, anesthesia, general surgery, cardiac surgery has been one of those entry routes. And there's special consideration if you spend enough time either in general surgery or medicine from other specialties such as neurology or other surgical specialties. There had been an issue with respirology, so for any of our US audience here within Canada, and so the respirologists, which used to be a lot of respirologist intensivists, not so much in Canada anymore. They're becoming a rare exception, and that was really because respirology had suffered in terms of their maintenance of training along the way. We see a lot more cardiology critical care, so double subspecialty, and that's because cardiology and coronary care units are now equivalent to level 3 ICUs being ventilated patients, and so cardiology in past hadn't had those skills to be able to maintain that. We have a growing group of infectious disease critical care specialists and a few GI, I think there's 3 of them in the country now, a couple of endo critical care, and 1 rheumatologist who trained in Manitoba. Our exam, which has no plans in changing, for those of you who have to, David and I have had long conversations about the torture of the Australian exam, was and will remain for the near future a 3-hour short answer, 2 3-hour short answer exams for certification critical care, and that's only been in place for about 13 years now. We were for a number of years as a relatively new specialty, one that we just had passed the in-training and didn't have an examination. So let's talk about entrustment. Who's had to trust their teenager to drive their car? What are the skills that you think that adolescent, 16, 17-year-old needs to be able to trust them to drive that vehicle at certain speeds, not end up with it dinged or them injuring themselves or other people? And so that is an entrustable professional act. We trust them to learn the skills over a period of time, training, to be able to drive the car. Let's think of what we do as critical care professionals in the same way. And so what did we do to develop this? Well, we took our specialty committee, we took all of the program directors of the 16 adult programs, and I think we've got 6 pediatric programs across the country. Myself as the chair and the vice chair and some additional critical care experts, and we sat us in a room for about 9 days in total, put us down and got some consensus about what we thought those entrustable acts were at the various stages of training to be a critical care physician. What were the milestones to achieve those entrustable acts, what assessment tools, what we need for that, and what were the required training experiences would allow us to get that. What I'm only going to give you right now is some very, very high level, because at the end of it, we ended up with about 20 total entrustable professional acts over the spectrum of the 2 years. Here's two examples of one that are similarly related. Transition to discipline, that's the first couple of months of training. And think about what we do as resuscitationists, how we have to resuscitate. Any of them that are bold are ones that we really think are crucially important milestones along that journey, okay? The ABCs. And if you look, the ME, the L, those are CANMED's competencies. So when we created these entrustable professional acts, there was a requirement that you had to have at least 2 or more of the CANMED competencies under that entrustable professional act. That makes sense to people. So you had to be able to demonstrate either communication, how you collaborated, the professionalism associated with each of those entrustable professional acts. Now let's skip over foundations and go to core. And now you're not just leading a resuscitation or managing the first few minutes of a resuscitation. You're going to manage the entire team as part of that resuscitation. So you have to know all of those skills about reassess and reevaluate, your situational awareness. You have to be able to use closed-loop communication. So you can think about the trainee at that stage and how you need to evaluate them to get to all of those points. Similarly, here's another one in terms of how we lead a multidisciplinary team in the ICU. At the foundation, within that sort of first year of training, they've just got to be able to prioritize the tasks, communicate with other physicians, build some consensus, maybe train some other trainees going through the unit, and allocate resources for patient care. But by the time you're almost ready to go to independent practice, well, you've got to be able to do all of that, integrate best practice into that, manage the mental and physical challenges of wellness in your own routine when you're leading and coordinating the delivery of critical care services. So that's a big entrustable professional act before you're going to be able to go out and be independent in practice. So those just 2 high-level examples. And people may come to me and ask me for the bunch of them. The one thing the Royal College has not decided at this point is to broadly share our entrustable professional acts as we develop this program. There's also a number of required training exercises. I've just listed a few. If we think about transition to discipline, maybe we need ACLS, PALS. Within critical care in Canada, for more than a decade, we've had what we call acute critical event simulation program, which is a 2-day course that we put all of our adult incoming trainees through. Physician wellness program that I'm going to discuss a little more. Spending some time with that RN or that respiratory therapist at the bedside, understanding the interprofessional things. Moving on in foundation, maybe we're going to start to take on a scholarly project. Remember that many of our critical care trainees may come from backgrounds where their airway expertise may not be as solidified compared to anesthesia or our emergency medicine colleagues, so we need to make sure that their skills are up by the end of foundation. The introduction of point-of-care ultrasound and attending our scientific meetings. Community ICUs are really important in the critical care community, particularly the adult side, bronchoscopy skills, teaching, presenting your work, and then on that transition to practice, actually acting as a junior attending, getting formal instruction and how to manage your practice. Can any of you remember when you went into training that you actually were taught how to manage your practice when you got out? No, I certainly was. So we're going to put that in there. And participate in hospital admin activities. Many of our trainees don't end up in academic centers, they end up in community centers, and they're often thrown into those committees right out of practice and learning how to actually run something. Wellness curriculum. Now this is a draft of our wellness curriculum. We've been working, there's a small subcommittee, myself and 2 other people working on this, but you can think about something. Do we tell our trainees that when they come in at the beginning of this, do they have a family doc themselves? Do they have a dentist? Do they go see them? We've built this so that the older trainees come and participate in wellness activities. One of the best experiences I ever remember was my program director who took everybody out one day and said, we're going hiking in the mountains in Calgary. It was a wellness activity. Our current emerge trainees go to a baseball game. That's their wellness activity. So just thinking about the things that build a curriculum for wellness so that we decrease some of those risks for our trainees. We've had some suicides within our community in Canada. What do we do for preventing suicides within our own community? So those are just a bit of a development of a wellness program. But we have to be able to assess this, and we have to be able to assess it in a different way than what we traditionally did. In our world anyway, we're on it for a week or a few days with a trainee, and at the end of that period, we'll sit down with them and we'll fill out a form. What we're now expecting is what happens in many other places is daily, almost daily workplace-based assessments. More frequent, focused on narrative comments, just giving some qualitative feedback, and turning our faculty not so much into the feedback person, but more of a coach. What could you do differently? And setting standards so that ultimately we're sending out our trainees to be safe. There's a lot of evidence suggests that at the end of that training, if you haven't met that standard, you're going to consistently have problems in your practice later on. We also changed the rating scale. So if this is the traditional rating scale that you're used to seeing on one side where it's, you know, you meet the expectations or you're consistently above, and you've got colleagues who do the 4s down the line, and everybody sometimes meets most expectations, we're throwing it out. One of our urology colleagues by the name of Wayne Gofton and his colleagues in Ottawa have started originally in the surgical world, what we're calling the O scale, which is, think about that trainee. Think about that trainee putting the central line in, right? The first time, they might have done a little bit, but you had to step in because they just couldn't find that vein. But by the end of it, you should be able to sit back, not even watch them anymore, and I didn't need to be there to do that. And think about that for all of those activities that we do, and that's how we're anchoring it. So it's going to be multimodal. We're going to use the O score. There's going to be narrative feedback. There's going to be mandatory self-reflection so that the trainee thinks about what they can improve. It's going to be frequent, daily. Now, here's the challenge in ICU. We don't just have our critical care subspecialty trainees. We've got all of the anesthesia, orthopedics, general surgery, everybody else rotating through that unit as well. And we can use simulation if there are skills that may be simulated instead of doing it in real life. So how's this going to work? Well, you take all those EPAs, you put them in this bundle, you drill down into the milestones if you need to. You do your workplace assessments in that practice environment. It builds a portfolio, and the responsibility will no longer lie with just the program director to make those decisions, but actually a competency committee who will take all of those documents, work with each trainee's advisor or coach, and build this document together at the end of it. You will not be able to pass one level until you meet all of those entrustable professional acts. Whoops, we're going the wrong way. Okay. So in conclusion, Canada's undergoing this big sea change. Remember, we have a single college for over 60 specialties and subspecialties in Canada. So this is our capacity to do this and do it as a big C for everybody, every physician in Canada. Critical care medicine, July 1st, here's where we're starting. We've already put a number of groups through. Anesthesia will be starting their 3rd year coming up. Otolaryngology, head and neck was in that first cohort. Medicine's going to be starting, internal medicine's going to be starting with us. And we made a decision in critical care to not move our exam until that point when all of our feeder specialties have gotten through competency. We need to monitor the impact on our trainees, on our ICU staff, and our patients. It will be important. And the trajectory of lifelong learning in the practice of critical care will be an expectation of graduates, and Dominic has been starting that work for the society. She's going to talk about that next. So ultimately, competency by design, as we've called this in Canada, is hope to improve the resident journey, and we need a better way to train our Canadian critical care physicians. And with that, I will say thank you, not only to all of my Canadian critical care educators who helped put these documents together, because it was a team effort, but thank you for you to listening. And if you want to chat more about all of this, there's some contact information. And again, come visit Canada in 2021.
Thank you.